Okay, there we go. Okay,
All right.
thank you for your patience, Dr. Mason.
Absolutely.
I think everybody here knows you or knows of you. I'll just take a brief time to say a few words. I believe you're a graduate of Dalhousie
Yep.
and your home residence is Stellarton,
New Glasgow, actually. Grew up in
actually
the West.
Glasgow. So
Yeah.
he's a hometown son. Uh, he's a graduate of the urology program at Dalhousie, and he went off to Minnesota to specialize in robotic treatments of cancer. He spent a couple of years there, and he brought back the knowledge and the technology to Nova Scotia. So with further ado, Dr. Mason's going to talk to us about the robotic program and the new opportunities to treat prostate cancer. Dr. Mason, it's all yours.
Perfect. Well, super excited to talk to your group again. Always lots of enthusiasm, and I know you spoke with Dr. Gabriella Illy, and she was very happy with speaking with your group as well. And so what I wanted to do a little bit tonight was talk about prostate cancer in general and talk about what we're doing at the QE2. So I am going to focus a little bit on robotics throughout the talk, but also just on the whole. What are we offering today? Because when I started in urology 13 years ago, it was a lot different. We had very limited options compared to what we have today. And through significant efforts by my colleagues around the globe, there's been huge strides made in prostate cancer treatment, and there continues to be. And so I just kind of wanted to share some of that enthusiasm about prostate cancer research and treatments that we have going on. My practice is in treating cancers of the urinary tract. About 50 to 60% of that is prostate cancer, and my research is heavily based in clinical trials in prostate cancer. So I figured we'd go through that. Please interrupt me at any time, and at the end I can talk about this stuff or anything else. So we'll get going here. So let me just talk. So my objective is really, I'm going to talk about, what are the various stages of prostate cancer, how do we treat based on that stage, and a little bit about side effects, because when we're choosing how we're going to talk to our patients and people with prostate cancer, one of the big things is, how is this going to impact them? What does it do in terms of side effects? So, how do we diagnose prostate cancer? I think many of you would be familiar with this. We do it with blood tests. The PSA, it's been a controversial blood test, but it does work. It's how the large majority of men are coming to us. We do see some men that present later who did not have PSA testing, and they do have symptoms related to their cancer, things like difficulty with peeing and pain in various parts of the body. And then the diagnosis is confirmed with a biopsy, which I think many of you have probably gone through, and some imaging tests. And I didn't really focus on it here, but we biopsies have changed a significant amount over the past 10 years as well. We have our standard prostate biopsies that we're doing, but we also have the ability to use pretty fancy imaging with MRI to actually target exactly what we're biopsying. And so we've gotten a lot better with that too. And that technology has been at the QE2 for the past 16 months, courtesy of the QE2 Foundation. So when we look at prostate cancer and someone comes in and we're seeing them, we try to put them and say, okay, where are we in terms of this disease? Is it what we call localized disease? And that means it's just in the prostate. It hasn't gone anywhere else. It's just there. Is it so-called what we call locally advanced prostate cancer? That would mean that it's just starting to spread around the area where the prostate was or is. We have this word called metastatic. Metastatic is just a fancy word that means cancer has spread somewhere else in the body. That's all it means. And then we have a final stage of prostate cancer where we say it's actually been resistant to some of our treatments. So despite all our best efforts in treatment, the cancer continues to grow. And that is the later stages, and that's called what we call castrate-resistant or hormone-resistant prostate cancer. So localized prostate cancer, that's where robotics come into. This is when prostate cancer is just in the prostate. It's not growing into things that are around the prostate. It's not spreading to other parts of the body. And we often look at this disease and we say, is it a low risk, somewhere in the middle called intermediate risk, or is it a high risk of this getting worse? And that helps us in terms of how we're going to treat this. And so this is kind of a picture of that. This is the prostate gland. The prostate is a finicky little organ. It's tucked deep in the pelvis, as you're all aware. Its sole purpose is a reproductive organ. It makes semen, and it's the most common site that men get cancer. It's actually the most common solid organ cancer that exists out there. So it is a very common disease. So how do we treat this? Well, it depends, and it depends on a lot of different things, but we can do what's called active surveillance, where we're monitoring actively and treating when needed. We can do what's called watchful waiting, and I'll talk about what the difference between watchful waiting and surveillance means. There's surgery, that's where robotics comes in. And then there's radiation therapy, and radiation therapy has exploded in terms of our capabilities. Essentially at the QE2 right now, we offer everything that you can find, save for a few things that you can only get in the United States, but we pretty much offer the gamut for radiation therapy. Active surveillance, some of you may be familiar with this. This is generally when we think that men are at a low risk of the cancer getting worse. We don't think that it's going to get worse quickly, or that we're going to miss this opportunity to cure somebody. And so the goal is to monitor somebody pretty closely and only treat them if needed. And that way we can avoid side effects. We don't get all the side effects of treatment. This is a little bit different and so how we do this, we monitor the blood work, we do a physical exam, as you're all aware of. We do a prostate MRI. This is new probably in the last 5 years. We do an MRI, that's an imaging test that looks at the prostate. And we do that in every man on surveillance, or at least I do. And sometimes it involves other biopsies as well to see if the cancer is the same. This is a little bit different than what we call watchful waiting. Watchful waiting is generally in patients that are older and have other health issues, and really just monitoring the cancer to make sure that it doesn't harm them, and treating them if it's at risk of causing harm, as opposed to going for a cure. And so we do this in many patients as well that might be a bit older and have other health issues. But so it's a little different than surveillance, where the goal of surveillance is still cure, just hopefully the cure is never needed. But then we get into my realm. My world is radical prostatectomy. This is surgery for prostate cancer. The word radical just means complete removal. And so it means removing the whole prostate. We often will remove some of the lymph nodes. Lymph nodes are like little balls of tissue that surround a prostate that cancer can spread to. And we did this through an open approach for many, many years, since well, the first prostatectomies were described in the early 1900s in Johns Hopkins. But they really didn't get popular until the 1980s, when people figured out safe ways to do this through open approaches. And we did that for about, well, here in Halifax, we did that up until 2019. This February 1st, we'll celebrate 5 years of robotic surgery. And to date, we have done 1,300 robotic surgeries. And with that would be about 1,000 of them being prostate removals. And that is between two surgeons, myself and Ricardo Rendon. And we've just actually hired a third. We have a third robotic prostate surgeon in Halifax. Her name is Dr. Andrea Kokorovic, and she's just joined us to help provide care to prostate cancer patients throughout the Maritimes. Robotic surgery, this is essentially the keyhole surgery. So we have been doing what's called laparoscopic or keyhole surgery for many, many years. Take gallbladders out with it, we take kidneys out with it. You can do lots of surgeries. The one thing about prostate removal is it's a tricky operation. It's a tricky place to get to, and doing it with just fine little sticks with your hands was challenging, and not many people actually did that. They did the open approach. When we got robotic technology, robotics allowed us to do minimally invasive surgery with cameras easier. We can do a finer job, and the robot really makes that doable. And the advantages of robotics are very clear. You get better visualization. We see a prostate in 10 times magnification in 3D view about 2 inches from the prostate. We never saw that in open surgery. There's less blood loss, less postoperative discomfort. Most of our patients go home the next day. I would say 9 out of 10 go home the next day, and there's probably improved outcomes in the long run. There's nothing wrong with open surgeries. There's lots of surgeons in Nova Scotia still doing the open prostate surgery, and many of them are very, very good at it. But there certainly is some advantages to the robot. Well, I've certainly, maybe I'm a little biased, so take that for what it's worth. But we solely believe in it. When we switched to robotic surgery in 2018, I think probably the number of open surgeries that we've done for prostate surgery in the last 2 years is maybe 1 or 2 out of several hundreds. So what is robotic surgery? Not at least currently, it doesn't do any operations on its own. It's essentially a tool that allows me to move the instruments inside a patient very precisely. The surgeon still is completely in charge of the operation, so we don't. There is no autonomous movements. It just makes fine movements easy, and makes like things like suturing or that sort of thing makes it a lot smoother and more precise. So, and that's a common question we get is, what is the robot doing? Well, the robot really is doing nothing other than what we're telling the robot to do. So that's robotic surgery, and we'll come back to that towards the end. Radiation therapy is another good treatment for prostate cancer, and it is offered in 3 different ways currently in Halifax. We can do what's traditional, which is called external beam radiation therapy, which is still a very good treatment. This is where X-rays are delivered over a period of several days. That number of days has gone down over time. It used to be 35 days. Now, in terms of treating prostate cancer up front anyway, that means not having had surgery before, it's only 20 days. It's pretty precise and used in 3D space. We just started a program called SBRT, or something that you'll see probably advertised if you've ever been to the US, called SABRE, which is essentially using external beams, but you're using in a very defined way or very refined way. And instead of doing 20 days, we can do 5 days of treatment. So we're shortening up how long it takes us to deliver radiation, which is a huge benefit when people are coming from farther away and they're not in the city. To not be in the city for 20 days and be only there for 5 days is a big deal. And then we do something called brachytherapy, and brachytherapy is like probes placed in the prostate. I don't know if anyone's familiar with or heard someone who's had gold seed treatment. They used to put gold seeds in the prostate for prostate cancer. Nowadays, what they do is they put these probes, kind of like a biopsy, right into the prostate, and it can deliver radiation, again, in 3D space, to deliver the radiation right to the prostate. A very good treatment for many patients, and provides pretty high cure rates with brachytherapy. I'm going to give a nod. I don't know if anyone is familiar who this picture is. Androgen deprivation. We call this hormonal treatment. Anyone that's been on hormone treatments for prostate cancer will be aware of this. Essentially, that male hormone, testosterone, that is the signal that causes prostate cancer to grow. That's like its food source. Without testosterone, most prostate cancers will not grow. And if you take away that signal, that prostate cancer, the cancer will shrink. It actually starts to shrink away. And this guy here is from the north end of Halifax. He went to Acadia University, and then he went to Harvard, and by way of Harvard went to Chicago. And this is Charles Huggins. He won the Nobel Prize. He's one of a handful of Nova Scotians to win the Nobel Prize, and he actually discovered this pathway. He discovered that if you take testosterone away, then you will essentially induce a remission, at least for a period of time, in prostate cancer. So a Nova Scotian who's made a big name for themselves in terms of prostate cancer treatments. And we add this to radiation in some patients because it's been shown to improve outcomes and survival. How do we choose? So yeah, we're choosing between surveillance, surgery, and radiation. Well, this is where it gets difficult. I often say that I treat bladder cancer, and sometimes the only treatment is surgery. It makes my decision and the patient's decision very easy. Here's your one treatment. This is what we're going to do. Prostate cancer is not like that. Prostate cancer has a whole bunch of different things we can offer. We just talked about a lot of them. And so we have to actually sit down and come up with the best plan for anybody that's in front of us. And that often is the patient's choosing. So you guys choose, and here's the options that we can offer. Here's the potential side effects. We're going to guide you through, but it's ultimately your choice. sometimes other health problems, maybe surgery is not the best idea, or maybe radiation is not the best idea, depending on other health problems. And then often how much cancer is in the prostate, because if there's a lot of cancer in the prostate, then sometimes surgery is actually not the best plan, because it's actually hard to get it all out from a surgical approach. So that's kind of, we're spoiled with a lot of options for prostate cancer, but sometimes it makes the decisions not clear cut. But we talk about side effects, and unfortunately, there's side effects with all of our treatments, and that's one of the problems that we have. We've certainly gotten much better, with surgery or so-called radical prostatectomy. Leakage, wetting yourself, that incontinence, that is a risk. That has gotten much better with the introduction of robotics and with refinement of surgery, but it is still present. Erectile dysfunction can happen with both radiation and with prostatectomy. We've gotten better over time, but it's not perfect, and that's a common side effect for many men. And then obviously the risks of surgery that are standard to all surgeries, and the side effects of hormonal treatments in men that are going to get those treatments are something we need to consider. And then one thing that we've kind of ignored, but Dr. Illy that spoke with your group is very heavily involved in, is the mental health aspects of prostate cancer treatment, because obviously it takes a big toll in terms of anxiety and stress and other pressures that we can't ignore. So that's kind of how we treat prostate cancer within the prostate. And then this is where it's, those are really exciting because you've got those new treatments. But when we get into prostate cancer that might be a little bit worse, this is where we've really improved survival. Some of the new drugs in the market have improved survival like several fold. When we had none of these new drugs, the average survival if prostate cancer had spread to other parts of the body might have been counted in 1 or 2 years. The average survival, if it's spread elsewhere now, is in excess of 8 years and increasing. So we've made huge gains in treating prostate cancer. So locally advanced disease, when we call it cancer, we don't want to say it's spread to other parts of the body because it hasn't, but it's spread into some of the areas around it. We call that locally advanced. So it's still just in the prostate, but now it's starting to grow into some stuff around it. It might be growing into other organs like the bowel or the bladder, or it might be spread to those so-called lymph nodes, those little balls of fat. But it hasn't spread other parts to bones and things like that. We usually treat this with radiation therapy and with the hormonal treatments. We can add in some pretty fancy medications that are available in Nova Scotia in select cases, and we do surgery in some of these cases, but not all of them. Oftentimes surgery, you will leave cancer behind, and we find that that's not the best approach, but there's certain cases where we do that because it is the best approach. Now, metastatic prostate cancer. So there's some cool stuff going on here. And by cool, I mean some really impressive stuff. And there's some stuff that's coming soon. This is where prostate cancer, unfortunately, has left the prostate and gone to other parts of the body. Prostate cancer, for whatever reason, has an affinity for bone. Prostate cancer spreads to the bone. That doesn't mean you have bone cancer. That means you have prostate cancer in the bones. And it's a little bit of a funny thing, but cancers in the body, where they've started is where they're from. If you took a piece of a bone tumor that started in the prostate and you sent it to one of our pathologists, they'd put it under a microscope and they'd say that looks like a prostate. So it is as opposed to thinking it's bone cancer, it's prostate cancer that's gone into the bones. Less commonly, it can go to things like the lungs and the liver, and rarely it goes to the brain, but that's a pretty uncommon scenario. When we get to this point, this is where we've made huge gains. This is not something, at least currently, that we can cure in most cases. The goals of treatment are to extend life. So that's our big goal, is to make people live longer. We want to make sure that people don't have symptoms, that they're not getting pain and other troubles from the cancer. And we also want to make sure that our treatments are tolerable, so that we're not trading one problem for another, because that's not what we want to do. So how do we treat it? Well, we'll use, these are big words, and I don't mean to focus on these. These are just, some of you may be on some of these medications, and being on these medications is something that we do. And so we use the hormonal treatment. We lower testosterone levels, and for millennia, since the 40s, that's what we did. We 1940s, when Charles Huggins figured this out, we lowered testosterone levels. And we did that until about 2015. And in 2015, up until 2021, there was a multitude of new clinical trials showing that adding these advanced drugs increased survival several fold. And so we use the hormonal medications, but we add on these new medications that drastically improve our survival. And they not only improve survival, but they prevent people from having side effects. They prevent people from having bone breakages and pain and things like that. So in our opinion, in my opinion, as someone who works in the world of oncology, anybody with advanced prostate cancer should be placed on one of these medications. And they're widely available. They're not without side effects. So these medications that lower testosterone levels result in significant fatigue, sexual dysfunction, hot flashes, weakening of the bones, increased fat. So we have to talk to people significantly about how we manage these side effects. So we're not naive enough to think that people don't struggle and have troubles on these medications, but we work with people to try to mitigate some of those side effects. And then at the end of the line, this is where there's a lot of work being done, and we've got clinical trials that we're doing where prostate cancer, despite giving these advanced treatments, has continued to grow. Treatment at this point gets pretty individualized and complex. We can use chemotherapy in some cases. And then the one thing I want to mention, because some of you may have seen it in the Chronicle Herald, is something we call radioligand therapy. And radioligand therapy is really cool. So this is what lutetium and PSMA is. I don't know if anyone's familiar with what PSMA is. PSMA is a type of imaging test. It's a PET scan, and a PET scan specific to prostate cancer. So PSMA is a scan, and now we have it available in Halifax, and it is very, very specific for prostate cancer. If you have prostate cancer that's spread anywhere else in your body, a PSMA scan will light that area up. You can see on the left side of the screen that all those little black spots, all of the little black spots, except the big one, that's your kidney, but all of the other little black spots are prostate cancer. And that PSMA scan showing all those areas of prostate cancer. Well, somebody got very smart and said, well, if this imaging test, if this molecule that you put in somebody and then x-ray them can light up prostate cancer, can you put some radiation on that molecule? So they have actually designed the molecule that runs this test. It gets injected into your arm, into your IV, and that goes to all of these black areas and delivers radiation directly into those areas. And you can see that on the right side is after the treatment. And you can see after a couple months of treatment, pretty much all of the black spots, except the ones that are not cancer, those would be the kidney and the bowels there that we're seeing, the leftover stuff in the middle, but all of the other spots that were prostate cancer are shrunk away. And this is really cool stuff. And this is this treatment, the imaging test that we see there on the left, these imaging tests are available at the QE2 as of the end of September. This treatment should be available in March. And so we've done this on clinical trial so far, but this should be actually something that we're going to be offering our patients with cancer spread, and it really is going to revolutionize what we're doing. So that's kind of how we treat prostate cancer. We try to base our treatments on everybody as an individual. So no two people that come through our door are the same, and it depends on the patient's wishes, some of their other health issues, where the stage of disease is and what's available. We do have almost everything in the world of oncology that would be considered guideline care. There's a few niche things that we don't have available yet. A team approach is needed. So we have a lot of people that help us treat prostate cancer. And then we have to consider a lot of other things like side effects, the genetics, are you going to pass this down to your family members? That sort of thing is becoming more and more important. And our team considers a lot. So we have people like myself. I'm a urologic oncologist and a urologist. We have our radiation doctors. We've got our medical oncologists. Those are chemotherapy doctors. We have an amazing prostate cancer nurse. Our prostate cancer nurse, Liette, is probably one of the most experienced people in the country in helping manage prostate cancer. Our pharmacists, our mental health experts, and our radiologists who read all our x-ray tests, and our pathologists who help us read all our biopsies really make a big team. And those are my kids. I go to karate with them on Tuesday night. but that's what we're doing at the QE2 right now, right? You know, our robotics program has I think, been probably one of the best robotic programs in the country. You know, we had a great team that started it, and we really moved it along. And sometime last year we did our 1,000th case, and now I think it's around 1,300 or something. So, so we are doing lots of them. I think, yeah, by the hundreds. So, thanks for listening to me. I'd love to hear any questions you guys have or talk about anything else related to the prostate cancer. So,
Are there any questions that you would like to ask Dr. Mason? Any questions? Robert.
If I could, still hear it finished.
Can you hear?
Yeah, I can hear him. Yeah.
Well, first of all, I want to thank you for doing my prostatectomy by robotics.
You're welcome. Absolutely.
Years, this Sunday it'll be 3 years, January 21st and 21. I never forget that date. So mine went is just almost perfect, I think, in terms of the outcome and in terms of the recovery time and the side effects or whatever after effects. So I appreciate all of that. One question came to mind as you were talking. Are there ever any occasions where you're doing robotic surgery and something isn't working right or something's not happening, and you have to say, no, we're gonna have to go in here? Does that ever happen?
It has not happened to me. It is definitely something that can happen. I've done about maybe 500 prostate removals with the robot, and it's never failed me once. I've had a few cases where the surgery was not possible. There are just very unique cases where surgery isn't going to be the best idea. And whether it's open or robotic, it just is not a good idea to take out the prostate, usually related to bleeding conditions and that sort of stuff. But I've never had to actually convert from a robotic to an open, but it is possible. I did have the robot malfunction on me once. In one case, the robot malfunctioned on me. One of the things about the company that makes the robot, Intuitive Surgical, is they have 25 years now of a track record, and their technical support is probably the best in the business. If it was 8 o'clock in the morning, so their tech support is in California, so 4 o'clock in the morning in California, and we essentially called them, and there was no waiting. Nothing. We just got tech support on the phone immediately. They were able to actually log onto our robot and fix the issue from California. So they can troubleshoot everything. So it is pretty slick technology. But theoretically, yeah, if we had a situation where the robot malfunction didn't work, then we could convert to an open procedure.
The only other thing I wanted to say is that, and I'm very appreciative of this group and the work they do, because there's still people who are losing their lives or losing quality of life because they won't. They find it too embarrassing, whatever, to come forward and to get the first look.
Yeah.
I saw somebody this week because when he went in, 10 days because it was far too advanced. And I know another gentleman who I tried to encourage to go on tonight. That knows he has problems, and there's that hesitation because they just feel that they'll be embarrassed by it all. And now that King Charles is going in, to get looked at, maybe some of them will disappear. Thank you for being with us tonight.
Absolutely, yeah. No, we've that is a common thing, and we always encourage people to get tested or to talk to their doctors or nurse practitioners about getting tested. It's been a controversial topic because there was honestly some poorly designed clinical trials that showed that PSA or prostate cancer screening didn't work. They were poorly designed, and if you look at the well-designed trials that were done in Europe, they showed that it worked. And so the Americans initially said, well, we don't think you should screen for prostate cancer. And then very quickly they changed their minds and said you should. because they recognize that the Canadian Preventative Services Task Force hasn't changed their recommendation since 2013. I don't know why. They're going to, and it's going to be coming soon, but they still have a recommendation against it based on faulty data. So.
Are there,
Dr. Mason, I had the robotic surgery with Dr. Renton, and side effects, et cetera, all went well. My question is with regard to the PSMA.
Yes.
Because there was still a little bit of PSA in me. Last May I was told about the opportunity of going to Montreal and having the done there. This
Yep.
PSMA procedure, is that for cure or is that for maintenance, or what is it? What's the result?
So there's two different PSMAs. There's the scan and then there's the treatment. So the scan is what we think of normally as PSMA, and that's what's available now. That is a diagnostic. And so that's a PET scan. It's actually, you don't have to go to Montreal anymore. Up until September, we were sending people, they had to pay and go to Montreal, but now it's paid for by the government and available in Halifax. And essentially what it is they inject you with a needle, a syringe full of this chemical called PSMA. And that PSMA preferentially goes and attaches itself to prostate cancer anywhere in the body. If it's in a bone, a lung, anywhere where prostate cancer is, it attaches to it. And then you go through the scanner and the scanner picks up those chemicals. And so that's for diagnosis. That doesn't do any treatment. That's just for diagnosis. And I suspect your next conversation with Dr. Rendon, they may bring up the fact that it's available here now. The other one is the treatment. And so that's called the lutetium PSMA, and that's a little bit different. That's where they take that molecule and they actually put some radiation on that molecule. And so that molecule then goes through your body and attacks the prostate cancer. Right now in 2024, that is only studied in very advanced disease. So patients that have failed all of your other treatments, but it's being studied in clinical trial in all states of disease, even earlier. In Australia, they're doing it in patients before they've had prostate removal. And so that data will be coming in the years, but right now it's going to be really advanced disease, and that will be available in Nova Scotia in March. So that the diagnosis one, the imaging is available now. The treatment one will be coming. And when I say March, I've worked in Nova Scotia Health long enough to know March means June. But
Thank you.
Yeah. So for some of us, for example, myself, going on 13 years, I had it the old-fashioned way. Anyways, I no longer have a doctor, so I'm working hard on trying to get a PSA test and stuff like that. I had one in July, and that was pretty good. But is this other test, is this more of an option, or is this something that if my numbers go up,
yeah.
start talking about it?
Good question. It would be if the numbers go up. So our traditional, without a PSA, like if your PSA test is too low, the imaging won't show anything. So our traditional imaging, that's the CAT scan and the bone scan that we do for prostate cancer, they won't show prostate cancer when it's come back until the PSA is around 5 or so. And that's a pretty high level after treatment. The PSMA, it's Health Canada approved at a PSA of 0.3. It probably actually, though, doesn't become that useful till 0.5. So the PSA is still a better test, the blood test early. It is more sensitive, so that if the PSA is 0 or close to it, you don't need the scan. It's not going to be that helpful. But unfortunately, if the PSA starts to rise after surgery, then that imaging test becomes very useful at that time. So we start with the blood test. If the blood test is normal, we don't worry any further because everything's good. If the blood test is rising, then we'll order the CAT scan.
Thank you.
Dr. Mason, I was at a seniors group the other day, and they were talking about health and stuff like that. So I took the opportunity to mention our group here. and there was probably half men, half women. And, majority of it, I think, would be in their late sixties and up. And, I got up and I gave a little speech and I said, you know, you get your PSA check still. It's not just an old man's disease. At one time, prostate cancer, I believe, was considered an old man's disease. I said, well, here I am at 59, I'm 52, I had prostate cancer, so I was not an old man anymore. But one of the gentlemen there said, and I said, get your PSA checked, and he said, oh, but that's not a good way to gauge it. It can throw people off, or his doctor said, you know, sometimes PSA goes up and down, and that's not really a good way to gauge it. And I said, well, I think that's outdated, and really PSA is the good way to find out. Was I wrong in that assumption, or?
I don't think so. You know, from my perspective, I mean, I was the primary author on the Canadian Urologic Association guidelines on PSA screening. And one of the things that there's a lot of misinformation out there, and that does stem from the fact that there was some faulty evidence. There was a clinical trial done in the US that was supposed to test screening with PSA, and it didn't really test that. They ended up not actually testing it, and they didn't find a difference. Essentially, the men that weren't supposed to be tested, so there was supposed to be a group of men that were supposed to be tested and a group that wasn't. The group that wasn't, they just didn't get tested on the trial. They actually went to their doctor and got tested anyway, because that's what the Americans do, right? They were off trial, and so they didn't actually prove it. And because of that, a lot of family doctors have been told that they don't need to test for prostate cancer, that it's not a useful tool. That, in my opinion, is just not true. The European data that was well done shows that prostate cancer screening saved lives. And so I believe in prostate cancer screening, but there is a lot of misinformation out there. We're hoping that the so-called Canadian Preventative Services Task Force changes their recommendations soon, to be in line with what we say, is that that prostate cancer screening can play a role. That being said, I don't think the criticism that we've gotten is totally unfounded. Not all prostate cancers need treatment, and not all elevated PSAs need biopsies. But if you were to go years ago, not that long ago, 10 years ago, we took out every prostate that had cancer in it, and we biopsied every man with an elevated PSA. And I think we probably hurt a lot of people along the way. They got the side effects from treatment, the leakage, the anxiety of the diagnosis, the erectile dysfunction, and many of them didn't need treatment. So as time has gone on, we've gotten better at selecting who we think should be treated and who shouldn't be, who should be watched. And we've gotten better also with saying, okay, your PSA might be elevated. Instead of just jumping into a biopsy, maybe we'll check it again. And maybe a few months later, it goes back down to normal and we don't worry. Or maybe it's still high and then we do the biopsy. So we've come a long way in doing it, but I don't think you're wrong at all. I think that prostate cancer screening plays a role. I just think it needs to be done right.
Yeah.
Are there any other questions?
Dr. Mason, Morley Shaw. 14 years ago, I had the brachytherapy treatment in George Dumont Hospital in Moncton. And then I had 22 external radiation treatments following that. And I got along fine till about 4 or 5 years ago, when the scar tissue started tightening and thickening, and I've had to go back to have it stretched. And now I'm self-catheterizing twice a day. Can robotic surgery open that scar tissue up so I don't have to go through that treatment or that exercise?
Unfortunately, probably not yet. I think in the future we'll probably be better at that, but no, not yet. That's a, unfortunate, and I'm sorry you're going through that. And that's one of the reasons about our treatments is that brachytherapy, external beam radiation therapy, and surgery all have some potential for significant side effects that can impact, your quality of life and things like that. And so it's something that we're all very aware of, is that, I think of myself as a pretty good surgeon, but I'd be lying if I didn't say I don't have some patients out there that have had complications from surgery, right? That's so, and all we can do is our best to try to manage those things and go along with them. But yeah, so not yet.
Well, I certainly prefer what I'm doing to the suprapubic catheter treatment, which was the other option. By the way, my wife says, hello, she taught you in music for young children. And probably,
Oh yes, absolutely.
yes.
You can tell her my kids were just at Music for Young Children tonight. I remember that fondly.
Are there any other questions for Dr. Mason?
Is Dr. Bell still involved with the ecology and training in Halifax?
Is Dr. Bell?
Yeah, he's doing cancer surgery about a year ago now. As he kind of reaches closer to retirement. So he is still seeing a lot of men that he has treated for years. He's a great resource to me because I called him once to see if you know, about a specific condition, and I said, you know, Dave, have you ever seen this before? And he said to me quite clearly, I've seen everything twice. Right. So he's got a lot of experience, and I very much value that. But right now his practice is mostly he'll diagnose men with prostate cancer and do the biopsies, and then he'll send them along to me or Ricardo or Andrea.
Is there an age limit where you stop going to your oncologist for, say, like a yearly check?
Not really. So I kind of think it depends. Like some men are at lower risk as time goes on, and I'll usually follow men for about 5 years with PSA tests, and after they've been treated, and after that, if the PSA is still 0, if they have a family doctor, I'll often ask the family doctor to do it annually forever. You know, I always feel that more information is better, and having that blood test is not harmful. As everybody's aware, that many people don't have family doctors, and I'll just continue to follow them on an annual basis until they get one. But no, prostate cancer is similar to other cancers, is that as time goes on, like if you get to 5 years after surgery or radiation and there's no signs of cancer, it's very unlikely it's going to come back, but it's not 0. We've all seen these, you know, unusual cases where 20 years later the PSA starts rising. So I think an annual test is a good idea.
So Dr. Mason, if we did away with the PSA test, right, what would tell us that we had prostate cancer? Like, that's the way I found out that
That's the problem, right? Advanced disease, right? People would present with trouble peeing, pain, and it would be too late. Most of the time, if you're getting symptoms from your cancer, then we've caught it we've been too long. So.
Any other questions?
Well, if you had your prostate out, like I did, your PSA should be like 0.000 whatever. What would make it go up and down? Like mine went back to 0.1 something, then it went back down to 0.00 something, went back to.
Yeah, great question. So a couple things. One is prostate cancer anywhere in the body will produce PSA. So if prostate cancer has spread somewhere in the body, it'll start producing that chemical even in the absence of a prostate being there. But after surgery, we'll often see these low amounts, particularly in the labs in Aberdeen and in Truro. In Halifax, we've actually set a limit. We've said if the PSA is below this level, they just call it 0. In New Glasgow, and we've done that for a reason, because in New Glasgow, in the South Shore, Yarmouth, Truro, they'll detect tiny amounts, and that will fluctuate. And the reason that is just random fluctuation in the lab. The lab's not that accurate. The blood test's not that accurate, is one of the things. The other thing is after removing a prostate, there's probably a few normal prostate cancer cells, or not prostate cancer, prostate cells left on the bladder. They're not related to cancer, they're just normal prostate cells, just a few of them left behind, and they make PSA. And so you will see these tiny small amounts of PSA in the bloodstream after removing a prostate, and those will fluctuate from time to time. But the hallmark or the marker of it not being from cancer is if it goes up and down. If you see a PSA that's bouncing up and down, that's usually non-cancerous. Cancer usually has a trajectory; it's a straight line, right? Well, it's a curve actually, but it goes up with time. So
how often do you come across somebody whose prostate is cracked?
prostate was
When you go in and you find out that a prostate is cracked.
cracked,
Yeah, when they open me up.
split open. With robotics, never, because we're finally moving it around. With the open surgery, just by the way you sometimes would pull a prostate up, you could crack it in your hands by taking it out. But with robotic, with open surgery, certainly you can crack a prostate. It's usually not of any significant consequence other than the pathologists get mad because they have to figure out what it looked like when it wasn't cracked. But in robotic surgery, I don't think I've ever seen a cracked prostate. So.
Dr. Mason, what if for PSA, what if your PSA is normal, but you still have cancer?
You still have cancer?
Yeah. You still get
Yeah, that's the scenario that we do see. There are cancers that don't produce PSA, or they produce small amounts of PSA, and so those are non-producing cancers, and they're trickier, right? Because they're hard to follow, they're hard to know what to do with. In those cases, I rely a lot on imaging, MRIs, CAT scans, bone scans, things like that to guide us in really what we're doing. But they do exist. They're not common. They're probably less than 10% of all prostate cancers.
Are there any more questions?
If there's no questions, I have a teeny little short story for the doctor. 13 years, well, it's 14 years ago and change, but anyway, 13 years ago, I had to explain to all assorted members of my family, including 2 international students who were staying at my house, what was about to happen. An 18-year-old girl and a 15-year-old girl. So I'm dancing around the question of the subject, trying to figure out how to get this out without too much gory detail. The 15-year-old was turning green, just not having any of this information. She doesn't want to know. And the 13-year-old says, "Oh, I know all about that." And I said, "What?" "Yeah, I know all about prostate cancer. My dad's a urologist, my grandfather's a urologist. We talk about it at the supper table." And I said, "Oh, okay." And I said, "You explain it to her then." A week later, I got a phone call from her father in Bogota, Colombia, saying, "Oh, well, what treatment are you having? Where are you going? What's your scores? All that stuff." And if you do the robotic surgery, and I said, "Well, no, because the nearest one is about 1,800 kilometers away." He goes, "Well, I've got one here. You can come down here. I'll do it for you." To this day, I don't know whether I should have gone or not.
Right, yeah.
I had it done in Nova Scotia, and side effects or not, it was the right decision. But
Perfect, yeah. And that's one of the things, like the people that were doing the open surgery, and there's still some of them, they're very good at it. Like Dr. Bell, he had done 4,000 open prostate removals. I don't think anybody would be poorly served with that guy taking your prostate out. He really knew how to do it well. And so, I do believe in robotics, but I think there's a lot of people that were treated very well with open surgery.
well, I had side effects and all that stuff. I still had no.
Yeah.
It would have gone the same way. I would have done it.
Yeah.
Over. But just bad luck on my part.
I'll complain to you next month when we do our phone call.
Sounds good.
Dr. Mason, I think that's it for questions. I just have one point. I've had many conversations with you. Our group is very fortunate in being able to help fund advances or treatments of prostate cancers for our members and our community. And so I'm hoping that you can direct us or assist us in maybe funding something that would really make an impact for your team and our group. So if you do that, I'm not putting you on the spot. If you could help us with that or have somebody on your team help us facilitate that process, we would
I
greatly.
definitely can. Yeah, I definitely can. And I've been thinking about that a lot, and we can definitely chat about some options. With robotics, our robot was very generously fully funded, and the second robot is coming. But I don't think it'll actually be for prostate cancer. It'll probably be for lung cancer, colon cancer, and those sorts of things. Because essentially we have been very successful with our robot. We use it all the time, and so we can't share it with anybody. And they're not happy that we're not sharing it. So they're going to get their own. But we are doing some advances in things like diagnosis. We're really switching up all the ways we're doing biopsies, and there may be some equipment that we're coming across, so we can chat about that, because it's going to significantly improve our diagnostics, but also decrease things like infections and side effects from biopsies. So.
Well, we would greatly appreciate any support you can do in that respect.
Oh yeah,
And
we do too.
On behalf of our group, we're so thankful that you were able to take the time and spend it with us.
Absolutely.
You're very highly regarded in this community, and the things that you've done and the people that you help is just phenomenal. So thank you so much for taking your time from your busy schedule to spend some time with us.
You're very welcome, and it's been an absolute pleasure to talk to all of you. So thank you for the invite. And Bill, I can send you an email, because I did have a meeting about something yesterday, and we can talk about some things that we'd love to have some help with the funding that you have.
Okay. Thank you so much.
Bye now.
Bye.
Michelle, I'm not sure if you're still there.
I'm still here, Bill. Did you want to stop the recording?
Yes, but I'd like to, on behalf of Michelle Ferris, who's Executive Director of the Aberdeen Health Foundation, helped us facilitate this meeting tonight. And I want to thank her very, very much so for helping us do this. Sorry for the little glitches with the sound system, but thank you for all your help. It's greatly appreciated.
Absolutely, no trouble. Glad we got it to work. And when you talk to Dr. Mason, ask if there's any of the stuff that he needs, or the diagnostic stuff that he needs, that could be at the Aberdeen.
Okay, we will certainly do that. We
All right.
Thank you so much.
Thanks, everybody. Have a good
So
night.
we can stop the recording now.
Yep. And you can end the meeting if you want to end the meeting for everybody.
Okay. Thank you.
Thanks.
And